Good afternoon, Mr. Calderwood.
Good afternoon, Lord.
No, Mr. Conn.
Thank you, Lord. Thank you, Mr. Calderwood. I've got to a point in proceedings when I'm conscious of the timing that we have available with you, and I need to move to questions that various parties have suggested. The net result of that may be that we jump around topics even more than we've done already. So I make no apologies for that. That's just the way the system will operate. Can I ask you, first of all, one question on staffing, just before I turn to some other matters? What you were saying, I think, was that if somebody had had a problem with the staffing levels, there would need to have been a process, and it would need to have gone through various hands and up to various levels. Now, I'm reminded by another of the participants in the room that we had evidence that Mr. Powery produced a paper in which he said, and the figures may not be exactly right, but take it from me that they're roughly correct, that whereas he had 63, I suspect that was FTE people, he needed somewhere around 111. And a paper to that effect went into the system, and according to him, went right through the process, through David Loudon, and came back to him with a message. It's been all the way up, including to Mr. Calderwood, and he says, you just have to stick with the budget. Does that help your recollection at all?
None at all.
Take it FTE is full-time
equivalent. I apologise, my lord. I think the witness understood my reference to
yes, I did.
That phrase. Can I then ask you something that cropped up just before lunch, where you referred to a minute in which Dr. Gibson had been involved and thought that it might show that Dr. Gibson had said one thing then and had changed her tune now. Now, I think you've now had a chance to look at it.
I don't think I said I should change the tune. I said the statement on the television the other week that she gave to inquiry was the opposite to the statement that was contained in that minute. That's what I said.
But in fact, do we see from the minute that she didn't make any such different statement?
Well,
Can we look at the minute?
Yes, please. It's bundle 27, volume 8, page 97. Now, this is what we understand you were referring to. Am I correct?
correct.
And as you can see, there are a number of people in attendance. Mr. Loudon sends his apologies. Professor Gibson is present. And there's discussion about progress being made. 2 rooms currently under scrutiny, other rooms which they hope over time will reach the level of specification required. And then we come to the bottom of the page and we see BH/DL, which is Billy Hunter, who I think was in an estates role at the time, and David Loudon, DL, we see from the top of the page. They were to write up a summary document which compared the old RHSC and current RHC unit in terms of specification and performance. The purpose of this was to provide formal audit trail that the new arrangements for transplanting children in the current RHC were as good, if not better, than the previous arrangements. That reads, at least on the face of it, as if somebody is to go away and try and produce a trail to show what you thought should have been the position, i.e. that it was better than...
No, that wasn't my interpretation of the outcome of the discussion. My interpretation of reading that just on Monday was that the group had agreed that was the position. It goes on to say the document needed to formally confirm that the specification and the document needed to confirm various issues, but it does say in the sentence before that to create a formal audit trail that the new arrangements for transplanting children in the current Royal Hospital children were as good as, if not better, than the previous arrangements. Now, that was the point I was referring to, and having read that on Monday, that was my interpretation. That's a minute of the outcome of the meeting.
Well, I wonder if we can, Ms. Conlon, maybe you're going to do this, but I think I'd like to understand what this minute is indicating. There's no year against the date, but our understanding is that this was a meeting that was held on the 7th of September 2015.
Correct.
Right. Now, it was brought together to identify the progress made in resolving the bone marrow transplant room estates issue in RHC and determine the position for the pediatric hematology oncology service in being able to start new cases. Now, my reading of this minute is that it indicates that 2 rooms either achieved or nearly achieved the required specification for a bone marrow transplant room, and that's 2 rooms out of 8.
Yes.
Right. And that means 6 rooms, which had been designated for bone marrow transplant patients, did not meet that specification, but it was planned that work should be done incrementally to bring them up to that standard. Am I
That was my reading,
right
my
so
lord, yeah.
far? Now, the Schiehallion unit has, I think it's 24 rooms, but I may be wrong about the precise figure, but it has more than 8 rooms. Now, how I read this minute is that it indicates that there's no specialized ventilation provision made in respect of any part of the Schiehallion unit as at September 2015, other than in respect of the 2 isolation rooms that either achieve or nearly achieve standard. Now, am I understanding this correctly?
My lord, I don't have the detail of the whole area. My understanding, and the reason I made reference to this in the context of the point about the starting point, which was, did we have the specification correct, and did we have the building to do it in? That was purely, that minute when I read it on Monday seemed to me to capture the spirit of the debate I had with Dr. Armstrong, which was, why are we not doing paediatric bone marrow transplantation? Because the board was under pressure from the government as to why a national service was not being performed. The outcome of this, when I read it, was that it was agreed that, subject to certain actions being taken, that the paediatric bone marrow transplant service would commence, and that these individual patients would be treated. I was really just trying to reference a point in relation to Mr. Collins' comments about where I understood the situation to be in 2015.
If we turn to page 98 and go to page, point 3 on the right-hand column. Now, the way I'm reading this, and I've already said this, is that it would appear that in order to discharge the national function in relation to bone marrow transplants, which you've just referred to, at that point, the RHC had 2 rooms to do that, but the plan was to, on complete further work, should be undertaken to fully seal the remaining 4 BMT room suites. On completion of this work, service would have an incremental uplift of 2 to 4 to 8 fully performing BMT suites over an agreed project time. Now, what I'm taking from this, and if I'm wrong, tell me, in September 2015, in order to discharge the obligation to provide a national service, the Children's Hospital had 2 rooms, BMT rooms, up to specification. They had another 6 rooms that were allocated for that purpose, but were not at that point up to specification. Now, have I got that right?
You have, my lord, in relation to the 6 rooms. I personally can't comment on what number of rooms we were allocated to the national paediatric bone marrow transplantation service. But yes, the minute sets out a plan that we can restart the programme because we have two, we would be, in the context of the people present, taking work to move quickly to 4, and would have a medium-term plan to get to 8 within this area. That was my reading of it. That was the only point in raising it, having read it on Monday.
And I mean, I've already put this to you, but my reading of the minute confirms that as far as the rest of the unit, that's the whole of the unit, other than the 2 bone marrow transplant rooms that we've discussed, did not have specialized ventilation.
I have no personal knowledge of what the output clinical specification was for the rest of the area.
Right. Thank you. Sorry, Mr. Cole. I'm just anxious to, because this seems to be a snapshot of the what was the situation in September 2015.
As far as Professor Gibson is concerned, and as far as at least the minutes reveal, she is present at the meeting but doesn't actually contribute directly to the discussion. Is that right?
Well, I'm not sure you can read into that from the way the thing's written up. I may have been wrong in my inference that Dr. Gibson said it, but Dr. Gibson was at the meeting. That was the note of the meeting. I therefore assume that she concurred with the actions and the statements.
Let's move on. I'm now moving to some completely different questions, so we can take the document off the screen. Thank you. This is a question that's been asked to 1 or 2 other witnesses. At the time when you were Chief Executive, did you have in place for this hospital a business continuity plan covering possible ward closure?
There would have been operational policies in place to cover disruption to certain services. There are certain services, for example, the National Paediatric Bone Marrow Transplant, where you cannot have alternative plans in place. The only alternative arrangements is to contact the English national centres and look to do that. But for all other areas, yes, there were contingency arrangements. The design of the hospital being single rooms is that, unlike the older hospitals, the Nightingale wards, you were unlikely through an infection outbreak to lose significant areas of the hospital, whereas in an older setting like Glasgow Royal Infirmary, you could lose significant numbers of beds.
When you say these would have been in place, do you recollect them being in place, or are you just assuming that was something that
these are the day-to-day operational requirements of the directorate teams? They are not issues that you would collate into a document that went to the board.
I suspect the question may be asked because at one point, Ward 2A was actually decanted into another ward elsewhere in the hospital, with the BMT people being moved one place and the rest of the patients being moved together. But that was done on an ad hoc basis after a lot of analysis. So that may be what's promoting the question.
I know nothing about the operational decision that was taken later after my retirement to undertake a significant redesign of the Schalian unit and the operational arrangements that were made during that period. That would have been discussed and approved by the board at the time.
Now, one of the issues that's beginning to emerge, in part from your evidence, Mr. Calderwood, is just how the management structures operated, what the chief executive did or didn't do, should or shouldn't have done, should or shouldn't have known, and so on. I think you can understand that already from a number of the questions that have come. Now, given what we've heard about some of the issues that arose during your tenure there, I've been asked to put this question to you. Can you tell us what principles and practices shaped your approach to corporate governance and risk management, and how you ensured accountability and transparency in board decision-making during times of crisis? Did you have any particular approach there?
No, I couldn't address that generic question in that way. My approach to issues would have been based, or was based on my experience and understanding, or in some instances lack of understanding, of the issues being discussed.
I suppose the question then, the follow-up question to that is, if there is a problem, a crisis, an issue, and we've had, for instance, the 4B shift back to the Beatson described as unprecedented. People who say they've never seen anything like that happen before and the like. So where a unit comes into a new hospital, takes a relatively quick look and says, not staying here, we're going. Did you have any issues of transparency in your mind when you were involved in that process?
No, I mean, 4B was a set of circumstances that had to be resolved in the interests of patients' well-being, and I think we set about it in a very inclusive and transparent way, and the conclusion was reached and the decision enacted.
I have asked you already about where responsibility ultimately rests in a structure such as the one you operated in. Who is ultimately accountable for ensuring effective risk management?
I'm sorry, could you amplify on that question? Protective risk management.
Well, one of the issues that's cropped up on various topics is whether risk assessment was done, whether any risk management process took place before X or Y was then proceeded with. The question, I suspect, is directed at who's ultimately responsible for making sure that you have systems in place which, as it were, ensure that effective risk management actually happens, as opposed to sitting in a book somewhere.
Well, it's the board's responsibility to ensure that there is systems in place, and the executive responsibility for acting the board's decisions is chief executive. Below that, each of the individual board directors and subsequently chief operating officer and directors have their roles and responsibilities.
Now, I'm told there's something called the corporate risk register. Is that something you're familiar with?
Yes.
And in the context of risks, the phrase is often used, who owns a particular risk?
Yes.
So who's the owner of the corporate risk register? On the risk register?
The risk register was compiled and submitted to the board, I think quarterly, and I'd probably looked at through the audit committee more regularly. It would be, well, I can't actually remember the actual group of staff that were responsible for pulling it together, but it involved obviously all of the directors having their input on their areas of responsibility. The corporate risk register for Glasgow incorporated many risks, including and most prominently financial and other risks. But as I say, it was reported to the board on at least, I think, quarterly basis.
So is it a board response that you've explained who puts it together?
Yeah.
Once it's been put together, who owns the risk? Is that the board?
Well, the board owns the risk. It then allocates actions to post holders depending on the risk.
And are water systems in the corporate risk register? Can you tell us?
I couldn't comment what was in the risk register at that time.
I suppose that the question comes to be this, I think, if I'm picking this up correctly, that if you create a risk register and you put risks on there, whether you're Division A or Division B or Division C, it doesn't matter. Is there somebody ultimately accountable for saying, right, there's the risk. I need assurance that we need assurance that that risk is being effectively managed.
Yes, but the corporate risk register of the board is an amalgam of a whole range of risk registers that work throughout the system. The ones that go to the board are obviously ones that require a corporate approach or input, and depending on their probability and the consequential outcome of a risk occurring, they are scored and noted in the red register to the board. The board would expect an action plan to be forthcoming to take the red register item off of red and to at least amber, if not ideally green. Many of these issues could involve issues that were both internal and external to the organisation.
So you say the board would expect this to be done. Would that mean that as the board's instrument, you and the executive would be responsible for making that happen?
For ensuring that the appropriate people were tasked to take it forward, yes.
Yeah. Because we're coming back to this issue of delegation. It's all very well to say, well, here's a risk that lands on the desk of Mr. Smith. I'll pass it down to him, but presumably somebody then needs to make sure that it's done.
Yes, the board secretariat chase up reports so that a report goes back to the board to confirm that the register has moved from red to either amber or green. Some elements of the risk register might never leave red. So, for example, the financial challenges is an issue between the board and the Scottish Government and other health authorities for funds. We may always view the fact that the funds are challenging. But in the context of a physical issue, then the expectation would be that over an agreed period of time, action would be taken, and clearly, if on the return of the updated risk to the board, it hadn't occurred, then I would be and then chased by the committee and the chairman to personally make sure that these actions move forward.
Can I just ask you something else about delegation? Because we asked a lot of questions in the witness, which you dealt with in your statement about schemes of delegation. Some of them were written down, some of them were not, some of them were perhaps capable of being worked out from standing orders, others not so clear. Clearly the concern of a number of participants, well, concern in some ways of all of the participants, but particularly of a number of participants in this inquiry, is focused on patient safety issues, so matters that can affect patient safety. Just giving us the benefit of your experience as the chief executive, how does the scheme of delegation ensure a balance between, on the one hand, operational autonomy by the people down to whom the thing has been delegated, and on the other hand, oversight to make sure that safety is maintained. How do you get that balance?
Well, it can be with difficulty in some instances, but it's basically cascaded. So at the lowest level with the clinical directorate, so there's a clinical medical director, there's a clinical nursing director, and there was the hospital operational director. They are charged with the responsibility to make sure that the discharge of the services from a patient safety perspective are followed through. Now, if they identify a patient safety issue that they cannot resolve, then they would escalate that up to the next level, which in this instance would be the chief operating officer, the deputy medical director, and the chief nurse. And they would then seek to help resolve this, because the point I was making earlier, it's about looking at the totality and seeing how you address and influence the required outcome. Clearly, if the issue still at that point was unresolved and all parties concerned remained of the view that there was a patient safety risk, that would be escalated to the board executive directors. And then depending on what the issue is, it would go through, certainly, if it was a nurse staffing issue, it would go to the board's director of nursing. And if it was a medical or infection control issue, it would go to the board's medical director. And ultimately, they and I would get involved, try and resolve it. But at that point, there would be visibility to the board that we were addressing an issue within the system or system-wide.
I understand that answer, and to an extent it makes perfect sense. I can't solve it. I need to push it up. Next person, they can't solve it. Up it goes. Perfectly logical. The only issue with it, and I want to put to you, is that it is dependent on the person at the lower level pushing it up. It's not dependent on the person above saying, I need to check with you what you're doing.
Correct.
So, was there any process for those, as it were, in that hierarchy to ensure that what should be happening at the level below was being done? Because otherwise, if Director X has a bit of a problem but doesn't tell the Chief Operating Officer, it sticks and nobody knows about it.
Well, that's possible in the system and the way it works, but as I think it was outlined in a number of the schematics that have been seen by the inquiry, there are professional lines of accountability out with the managerial lines of accountability. So if a director was not to accept or address an issue that was raised on in this instance, call it patient safety, then both the medical and the nursing heads can come out with the managerial line and escalate the issue to a higher level. So it can't be buried because the director didn't seek to see it with the same concern as others.
So there's no downward supervision. You're dependent either on it coming up from the lower person in the hierarchy, or, as it were, coming out sideways and going a different route.
Well, that's the way the system works in the context of the issue. The director of nursing will carry out her own or his own views into the quality of the nursing care provided in all of our establishments. The medical director will interact with all the medical staff in a downward way about the quality of care and patient safety. So there are individuals looking at the system in a downward way, as well as the primary route being up through the directorate chain. I, as as the chief executive, would have general conversations and performance management with the chief operating officer, and could make inquiries if I was concerned about anything.
Thank you. One of the topics I didn't ask you to go to in your witness statement for reasons of time was the introduction of the infectious diseases unit into the new hospital.
Yes.
Which was not originally planned.
No.
And summarising, this was not a decision that you had been told about at the stage when you would have expected to have been told about it, if I can put it that way.
Correct.
And you described as some heated communications. Now, was there any process for dealing with something like that where a decision is taken without your knowledge? Was there any sort of management process that should have gone through?
In that particular instance, there should have been a paper to the board highlighting the reasons as to why the infectious diseases unit at Gartnavel General should also transfer to the Queen Elizabeth, because it was not in the original clinical strategy underpinning the Queen Elizabeth Hospital. So that the chief operating officer should have brought a paper to me, and then personally he would have then taken it to the board, so that there would be transparency around the issue and an understanding of the reasons why we wanted to make that change.
So in this case, the system didn't work in that way, in the way you would have expected it to work.
No, it didn't.
I suppose I'm trying to think of, there was a process that should have been happened, it didn't happen, but nevertheless, the decision was taken to move the infectious diseases unit in, apparently without going through that process. Was there any other tripwire that might have been triggered that should have picked this up?
At a board level, no, because when the clinical staff and the managerial staff agree they want to do something operationally, and the chief operating officer takes a decision to support it, there are no red flags raised anywhere in the system that would cause me to know it until I start walking about and see an empty building where it should be occupied.
Thank you. Again, on occasion, we'll find we're going back over ground that you may think you've covered, but bear with me. The Schiehallion unit. Now, we've just discussed some of the events after handover. Did you get any assurance during any of your routine, more or less informal meetings about the design and build of the Schiehallion unit?
No. The Schiehallion unit opened in June 2015. It was a centrepiece of the late Queen's visit to open the hospital, was to the Schiehallion unit, along with the First Minister and others. So at that point, all appeared to be progressing satisfactorily. The issue was raised by infection control as part of their routine programme, that they were concerned that the environment was not correct. You've seen the minute of the meeting that Jennifer Armstrong chaired to address A, the infection control doctor's concerns, and B, agree a plan forward so that the service could safely continue. So at no point up to, and we're now into October 2015, was anybody saying that we didn't get what we specified. The concern was to make sure that we had specified what we needed.
Now, I may be misremembering, but was it not an issue under which HEPA filters had not been fitted?
That was during the commissioning period.
2A.
Correct.
Which you learned about and were clearly not happy about. Is that fair?
That would be fair, yes.
And did that not raise flags as to what processes had been in place, not so much for the HEPA filters, but to check that the rooms that the HEPA filters were not in were correct? I just wonder.
At the time, the absence of the HEPA filters was identified during the commissioning period. Multiplex then set about rectifying the error. That rectification programme was achieved within the timescale agreed, and the rooms were signed off as being acceptable. The truthful answer is that the unit should never have been signed off without the HEPA filter units, because that was the whole purpose of the commissioning and validation process. It takes us back to the conversation at the end of yesterday evening, where we were talking about Capita. Capita signed off on behalf of the board that the room, as fitted, was operationally compliant. Now, to you and I going into the room, all we would see is the grill. And therefore, there were 6 grills in the room. Before the grill was put up, it was Capita's responsibility to assure us that above the grill was the HEPA filters, which patently were not there, and therefore when the operational team switched on the filters to check that they were working, clearly there was nothing to switch on. Hence it was discovered. So the process we had in place failed. Well, it failed in the context of the room should never have been signed off. It was caught during the commissioning period, the distinction you were making this morning between validation and commissioning. So it was caught in the commissioning period, but should never have been validated.
Okay. We've put the same question to other witnesses, and that is basically this. We now know, with a bit of hindsight, that validation of critical areas didn't happen at all. Validation as distinct from commissioning in the way that we discussed earlier. Here you have a part of your key area, flagship area, whatever you want to say, jewel in the crown, national centre.
Yeah.
And you've just discovered that it couldn't have been validated because it couldn't have been validated without the HEPA filters in it. The question we've asked a number of other witnesses, we'll just ask you, is did it not then occur to you to say, hold on, I mean, whether this had been done properly, could it easily have been identified by somebody asking to see the certificates or whatever it was? It clearly wasn't. Should we not be stamping our little foot and making sure we've got everything in line for all of the areas?
That's a reasonable assertion. My conversations with the project director, I can't quote them verbatim, but my recollection would be that I did ask him if there were any other areas that we had any concerns about that we wanted to recheck.
I just take that from you again, Mr. Calderwood. My recollection is
that as part of discussing this particular incident, the absence of the HEPA filters, whether we were, or in this case, me asking him whether he was clear that all the other areas were fine, were compliant. But it was part of a general conversation. I didn't ask for a complete audit of all that had gone before or hadn't gone before, with the benefit of hindsight.
And when you were using the expression "we're fine or compliant."
Yeah.
I rather assume that what you would have in mind were conform to contract.
Yes.
Thank you.
Yeah.
Now, it's been suggested I may have touched on this point yesterday, but the question I've been asked to put to you is this: which group or committee was responsible for ensuring statutory inspections such as Legionella checks were followed up with appropriate action? In other words, don't mind the individuals down at the states level. But which committee was in?
There's the Water Safety Group.
The Water Safety Group, the board's Water Safety Group.
Well, the Water Safety Group, which didn't contain board members, but
no, I'm sorry. My fault. What I meant by that was the board-wide Water Safety Group.
They should be getting a report from the Director of States that the statutory compliance had been performed.
Were you aware, as time went on, 2015 drifted on into 2016, no doubt, that infection prevention control teams were raising concerns about the state of the hospital environment?
In what sense? I was aware of and was involved in a number of firefighting incidents with regard to, I was aware with regard to Dr. Armstrong's work in relation to the Schiehallion. I personally got involved in 4B, and I latterly got involved in an issue with regard to infectious diseases and the use of isolation rooms within critical care. More generally, on I don't know if you're inferring on a daily, weekly, or monthly basis, infection control continues to raise issues. That would be, no, I wasn't aware of that, and that would go through the infection control management structure reporting to the board, Infection Control Committee, and Dr. Armstrong.
Okay. With the benefit of hindsight, and bearing in mind we're approaching the end of the oral sessions of the inquiry, so we're starting to think about what could we suggest, what could we offer other. Has anyone got any easy answers here? And we've asked, therefore, questions of a number of witnesses about anything they could suggest. Do you think that the structures and leadership approaches that were in place at the time in the new, which related to the new hospital, were adequate to safeguard patient safety during this project? And if not, what could you suggest to make things better?
I believe in relation to this project that at each of the stages, the board brought to bear both internal and external experts capable of leading that stage of the process, be it procurement, planning, and then ultimately construction. To the extent that individuals or organisations didn't perform their roles adequately, it is difficult to see how you set a system above that is second guessing the experts below. There has been discussion within the health service over many years about the fact that we as staff rarely in our career do more than one major construction project, and therefore there's no in-house learning carried forward. So Mr. Seaborn would have taken this project forward over a 6 or 7 year period, and in the context of his career would never have expected to be a project director on such a project again. So there has been discussion over many years in the health service about whether you could have a cadre of people who would, in essence, flip from one organisation to another, bringing that expertise and practical knowledge. But that's a role in a career that over the years has proved to be difficult in those discussions, because there's no rolling programme of investment in the public sector, well, specifically in health. So to have a cadre of these people, there could be 2 or 3 year period where they're, in inverted commas, not working, because there's no schemes to roll on to.
Could I just pursue, with Mr. Collins' permission, that point? And essentially, my question is, does that argue for the position of project director to be sourced from outside the health service with an appropriately qualified professional, or would that raise challenges which are sort of additional problems? I mean, we've heard that Mr. Seaborn had an engineering background, but
Yes.
essentially I understand his skills to be as a health service administrator. And incidentally, I think we heard from Mr. Gallagher that who's essentially his skill, if I'm remembering correctly, although his skills are financial, he had some experience in having been a project director in relation to something, I think, outside GGC. So would your observation about health service officers being asked to be project directors, so perhaps quite large projects, argue for that role to be outsourced to a professional, or would that bring other problems or difficulties or challenges?
In historical discussions, the view was that it would have been preferable for the project directors to have health service experience and be knowledgeable about the clinical issues and clinical adjacencies and interacting on a regular basis with medical and nursing staff. The experience we gained through the PFI projects, where the point you were making about Mr. Gallagher was one of the project directors in Lanarkshire, in one of the Lanarkshire PFI hospitals. These were particularly, in the PFI sense, financially, the kind of project director role had more to do with understanding the financial aspects of it, but with a team below them to do the clinical input. So in my discussions over the years, that's been the debate about how you would get someone competent and skilled with health service experience and be able to remunerate them at the level consistent with these roles, and give them a programme of work which they could see stretching for an acceptable period of a career. And going back to earlier in my career, we had what was called the Common Services Building Agency, which was an attempt to do just that, a group of professionals who did Scottish health service building projects. And that was disbanded for various reasons in the 90s. But there has been discussion since about how one might create a more relevant organisation going forward, and that's been the challenge, as to how to get people to voluntarily go into that as a kind of career, because once you say most people do it once and then move back into a senior operational role. I mean, had Mr. Seaborn been younger, for example, he would have completed this project and he would have taken on one of the director's roles within the board going forward.
Right. What I take from that answer is that consideration has been given in the past to who best should carry out project director roles.
Discussions have taken place just generally on how to harness the experience we gain within the health service in taking forward a major building project, and how to make sure that learning can be carried over to another. But because we have historically all been employed by our local board, most health boards will only take forward one major project in the kind of reasonable aspect of a kind of 20-year career.
And the other thing I've taken from what your answer is that were a health board to outsource the project director role, it would lose the particular health service experience which someone like Mr. Seaborn had.
Correct.
Right. Thank you.
That a very interesting discussion. Thank you for that, Mr. Calderwood. At a slightly more micro level, I just put this to you for any thoughts that you have. You and sundry other witnesses have spoken during the course of this inquiry of getting assurances from the project director. The project director told me, the project director assured me, I asked and the project director told me. Assurances which in some cases turned out to be somewhat short on substance on the basis of what we have. Now, I wonder whether a smaller step that might be taken would be to introduce some form of much more demanding scrutiny of assurances, communications from the project team. I mean, for instance, we even had evidence from some witnesses early in the inquiry of asking questions of the project team and being unable to get an answer at all. They just weren't responding. So I'm just wondering whether some form of more demanding audit requirement of what the project director says might have helped. Any views?
Well, to have an organisation that sets up an organisation to audit the organisation with the appropriate skills at both levels seems, bureaucratically burdensome. To have a suite of documentation that requires the project director to submit that documentation with evidence to the client, in this case the board, on a more regular basis may well be one of the elements of learning. But in any scheme of delegation and the appointment of a senior executive, there is an element of trust assumed from day one. If performance is poor and that is noted by others and reported, then you would take steps, as I said to in my statement, the board would expect me to take steps to either help that individual to improve or to move that individual on so that we have the right people with the right skills in the roles. It has not been, in my experience, the case where either I or my previous bosses over me would automatically say, I don't believe what you're saying, give me external, validation of what you're saying. That's not been my experience.
The reason I ask that is some participants have expressed surprise that when the hospital was handed over, it seemed to be handed over on the basis of an oral assurance from Mr. Loudon that everything was fine, everything was safe to go, everything was ready to roll, whatever phrase you cared to mention. Now, if you were employing an external private contractor to do a job for you, and he appears on site and says, okay, Gov, all okay here, you'd be more likely to say, well, thanks for that. I take it your report with all the supporting structural certificates or whatever it is you needed will be with me this afternoon or tomorrow or whatever it is. But that doesn't seem to have happened here, because otherwise, for instance, it would have revealed what only just turned out much later, that no validation had been done. If somebody had said, good, but David, you have to jump through some hoops here, you know that, give us the stuff. So that's why I'm asking the question.
Well, no, I appreciate the question, but there is what we did at the time, and there is the conversation I'm having with you this afternoon, 10 years later. Truthfully, at the time, when we agreed to accept the building in February 2015, there were certain steps that had to be taken. We had to have a certificate of occupation from the council. We had to have various other documentation in place. So when I speak to the project director to say, David, have we got the necessary paperwork? And I am told that we have. That might have been naive on my part to not say, no, I don't believe you, just go to the cupboard and bring them all out. But my expectation when I ask the question is that he has got the documentation, because I don't believe, or didn't believe, that there was any reason to tell me an answer that wasn't truthful, because, as I keep saying, from the board's perspective, people were not being put under pressure to do something. That the project, from the board's perspective, looked to be going really well. There was very good partnership working between the project team, the chief operating officer and his clinical groups, and Multiplex. That all appeared to the board to be a very positive set of experiences. The commissioning period thereafter, again, in my experience, when I had done these projects, or smaller projects, obviously, in earlier parts of my career, there is a documentation checklist that you would expect these people to go through. And that brings a bit of check and balance into it, because they're not starting from, you've told me it's okay, so I won't test it. Their job is to put all the equipment in place, everything in place, then switch on the plant, and it needs to work. You allude to the external versus internal. This particular project, had both. We had external people carrying out critical tasks on behalf of the board.
I suppose I'm not suggesting you would say to Mr. Loudon, I don't believe you, go and get the paperwork. But you might say to him, can you send me the paperwork, David? Because if I don't ask for it, somebody else out there is bound to say, have you seen X or Y? There'll be ways of doing this without making it hugely bureaucratic, would there not? But nevertheless imposing a discipline to avoid reliance on oral assurances.
Yeah, but I can only comment on what I did at the time, and the confidence I placed in that process, of that way of working. The documentation for this particular hospital would run to many thousands of pages, most of which would be particularly unintelligible to me. So I'm not actually, if I was a smart project director and I had a chief executive who was being too nosy, I would send them lots of paperwork that he or she probably couldn't determine whether it said the right or the wrong answer. That's the way the scheme was set up, to have, we expected the right people with the right skills in the right roles.
Can I ask you this, and it's really a follow-up to a point his lordship put to you about what he took to be something that sort of emerged from your witness statement, although not perhaps stated directly. The question I've been asked to put to you, do you accept the closure of the Schiehallion wards was due to patient safety risks associated with the wards, or do you believe that positioning and decisions made by what you call the new IPC doctors moved the goalposts, thus precipitating the closure?
At the time that the unit was deemed not to be appropriate for the patients, which I think from memory was sort of late June 2015, through to the resolution of that issue in the service recommencing in October 15, I think was, as I have said it already, my understanding started from, did we ask for the right specification and did we get it? So the answer to that starting point was yes. Why is the infection control team now saying that's not enough? And the minute that we discussed after lunch encapsulates the outcome of the work that took place over that 3 months to answer those questions and create an environment in which the service could restart.
Can I ask you something completely different? Given that we're talking about what management should and shouldn't know, and looking to some of your answers earlier in your evidence when you've talked about, well, I didn't know the technical details, I wasn't involved in detail. Am I right in understanding that in April 2014, you and a number of others, including Mr. Loudon and Mr. Archibald, went to Australia to visit a hospital there to try to get useful information about handover issues in hospital projects?
That's correct. In April 2014, we went to Port Royal Hospital in Perth for 3 days to discuss with the team there their commissioning processes in preparation for our own commissioning programme. And as that particular complex had been built by Multiplex, to talk to them about the handover issues and whether there was any learning there. It transpired when we arrived that due to a major failure with their external IT supplier, the hospital wasn't operational. It had been due to open at the Christmas of 2013, but the statutory authorities in Australia had outsourced their IT provision, and there were ongoing operational issues about getting that up and running. So what we got was quite good information in relation to the commissioning programme, not least some little learning points that we would never have twigged with regard to transferring clinical teams in and transferring new ways of working into that were built into the design of the hospital and into working in real life, in the sense of, although they were not operational, they had gone through all of the teething problems with the clinical teams.
And when you, I think I'm right, I'm just checking, you, David Loudon, Grant Archibald, and I think David Stewart.
Yes.
I can't really ask you, your position, having gone out there and picked up these learning points, what did you do with them when you got back? Did you have some kind of seminar or briefing, or who did you pass them on to?
Well, the individuals took took back the general learning. So, for example, one of the kind of points that I ended up getting involved in, just in the side, was meetings with the various medical groups to talk about the new ways of working in relation to, they were all losing their offices up until 2015, you opened Queen Elizabeth. Every NHS consultant had their own office, not to say some of them had their own car parking spaces. So I ended up meeting most of the medical staff societies to talk about the fact that we were going to hot desking and shared open space, and that the site was having no dedicated car parking, but car parking permits based on use. And at that point, quite a lot of consultants would not qualify for one of these permits because they didn't actually leave the hospital. Their working day was in a single location. So I decided I would front up those meetings, which were usually in the evening and boisterous.
Can I just ask you one question about water, which I've been asked to put as a follow-up to the exchange we had way back at the start of your evidence. I mean, you said you went with knowledge, you didn't know you were the duty holder and so on and so forth. Did you come to a point where you did check that systems were in place for dealing with the various water responsibilities?
Yes, I was aware of the Water Safety Committee. I was aware of the scheme of delegation setting out the responsibilities on the Director of Estates, the Chief Operating Officer and the hospital directors in the structure that we introduced in April 2015.
Did you do anything to check it was functioning?
No.
If I can come to some other questions I've been asked to put to you. We are jumping back again, back to the ventilation derogation. Just use that phrase for simplicity. Now, your position is that you were not aware of it, and therefore the board wasn't aware of it. Can you remember when you first found out about it?
No, I think in my statement, I said I became aware of it during general discussions after 2011, but I couldn't recall exactly in what context and in discussions with whom. I think the key that we were discussing was that at the time of signing the contract on the 18th of December, my attention was not drawn to any, in inverted commas, movement from a mandatory to a non-mandatory standard.
Now, we know from evidence about what happened later on, particularly post-2015, that a number of parties thought they needed to try and investigate why this had happened, what had happened, why was it done, and so on. Did you take any such steps when you first heard about the derogation?
No, because the information I had, and to this day still have, is that in the generic clinical areas where we, in inverted commas, the project team on behalf of the board, accepted a ventilation strategy based on 3 air changes, not 6, supported by chilled beams, was acceptable.
Well, I mean, you say the board had accepted that. I mean,
well,
what you actually mean by that is the project team
as the board's agent.
So, I'm just wondering whether it occurred to you, given that you were the CEO in charge of governance, that you ought to at least try to find out how this had happened, why you didn't know about it, perhaps why Helen Byrne did or didn't know about it, and so on.
Well, we're going way back into the mist of time and trying to stick to my oath about what I knew and what I didn't. The position up to and signing the contract in December 2009, Helen Burns, project director, supported with Mr. Seaborn, in some context or other, in developing the emerging ventilation strategy, accepted a design solution that was, as far as I'm aware now, was accepted by the board's technical advisors as being acceptable, and that decision was able to be made by the board to go with that strategy, and all of the sensitive clinical areas had their own specification for ventilation, etc.
Well,
So at no time to me, when I became aware of it later, at no time was it ever presented to me in the sense of we had to do something and we have chosen not to. That would have raised significant red flags, which would have required a detailed report to be prepared and submitted to the board.
the reason I ask is very simple. That one of the questions that has arisen here, and I think it's a mystery as much to us as it is to the NHS GGC team, is why no one could find any paperwork on this at all through any of the systems that were in place to manage this construction job. No one could find anything. And that's why when people came in 2015, they had to go, what has happened here? And dig back and ask. Now, if it had occurred to you to say, well, when I was signing the contract, I didn't know anything about this. Did somebody give me that? Helen, do you know about it? Did it go to the project committee or anything? It might have raised it a lot earlier. I suppose this is the question we're trying to get to.
Well, as I say, when I became aware, the exact date, I can't comment. It would be, as I say, after 2011, during the construction. I was advised that the decision to accept that strategy was reasonable and was within the board's ability to agree to it, that it was not breaking any mandatory guidance.
Well, I understand that, but you keep saying the board. What you were told was the project director had agreed this. You were not told, as I understand it, anyone further up the chain.
No, absolutely. No, absolutely. I use the word board, meaning that it was within our powers, i.e. as a statutory body, right, to accept a ventilation strategy not of 6 but of 3, right? Because the 6 was guidance, not mandatory. We have discussed and agreed that the use of mandatory, it refers to the contract specification where we had put the air changes into the mandatory column and then the project director agreed to take it out of that column and put it into the advisory column. Now, so when I became aware that it was 3, I was then told that simple thing.
And it's interesting, if you'd read the contract, which I know you didn't for very good practical reasons, you would have found that the employer's requirements still contained SHTM 0301 in the list of mandatory compliance documents. Albeit that in this case, a derogation from it had been agreed, and that's why we've been using the question of derogation. But I suppose that the question is simply, did it occur to you to go and ask somebody else how this had happened without you knowing about it?
No, because the way it was explained to me at the time was that it came out of the kind of narrative, iterative process of design evolving and hardening up in the context of going from, as I referred to before, the high-level outline 1 to 200 drawings down to the detailed 1 to 50 drawings throughout the building. So it was explained. It didn't register any bells with me that it was an issue to double check or to do any more about it, because it was explained as being technically competent and appropriate. The key areas were that the ventilation strategy for the specialist areas was correct and in working.
Can I come back to some other topics that I've been asked to put to you? Whatever your recollection is, this inquiry has heard evidence that the estates team at the hospital was under significant resource pressure. And the result of that was that critical infrastructure was not maintained, maintenance was not done. I mean, the horn tap maintenance wasn't done, notwithstanding it being said to be critical. The DMA Canyon report was not actioned when it should have been, just to take two examples. Now, do you accept any responsibility for that having occurred?
No. The original staffing profile for the hospital was designed by and set out by the professional estates management. Take the figure you quoted, which I'd never heard before, to get that staffing requirement wrong by 90% is unbelievable, that you could have a professional group of estates managers that could look at something and get it wrong by 90% within months. We have talked about, we have to differentiate between your two examples. The horn taps absolutely should have been done. It was there, the man responsible was at the meeting, the man responsible agreed to do it, and the man responsible, then you're telling me, didn't do it. The DMA Canyon report is a mystery to me because it was a no-brainer. It would have been paid for. It had no resource implications at all to Mr. Power and his team. It would just have been handed over. Multiplex would have done most of it, and they would have billed us for the bits and pieces that were not part of the defects. So the DMA Canyon is just an astounding issue to me. To get into the nitty-gritty of why the Estates Department, having agreed the structure, then very shortly after opening decided it was so wrong, I don't know how you get there. That's I've never come across managers starting with an opening number getting it so wrong. The other interesting part is that over 70% of all of the equipment in the hospital was brand new and therefore covered under maintenance contracts by external suppliers. There was a range of external maintenance contracts for specific specialist equipment and plant. And the major boiler plant, the major heavy plant, was covered by a 2 years warranty with the contractor. So in the opening year, I am surprised to hear that people were under excessive stress and workload. I would have expected that stress and workload to build up in subsequent years as more and more responsibilities transferred to the day-to-day estates team. I would not have expected it in day one.
Another suggestion I've been asked to put to you is that the way the governance culture operated while you were chief executive created a situation that had an unfocused approach to risk management and didn't create robust systems for escalating concerns. Now, do you agree with that proposition?
No.
And the result, it is suggested, of all of this is that environments were created in which, as we've heard, standards, whether it's water or ventilation, were consistently not as they should have been, and accordingly patients were put at risk. You agree with that?
No, but can we be clear? Are we talking about that staff at the Royal Infirmary or Gartnavel or Stop Hill or Victoria are all saying that they didn't do their maintenance or they didn't have risk in place? Or are we talking only about the Queen Elizabeth University Hospital?
We're only talking about the Queen.
Well, I'm chief executive of the whole organisation, and if I can put systems in place in 90% of the organisation, why would I not have that same situation in the Queen Elizabeth? The board's responsibility are for board-wide issues and policies. The water policy, all policies are board-wide. They need to be monitored, that they're being delivered everywhere. We're over 40 premises, major hospitals, which put together are as big as the Queen Elizabeth campus. It is surprising to me that everything is inferred as being broken at the Queen Elizabeth, but working apparently everywhere else.
Well, of course, we don't know what was or was not working anywhere else. We only know what's happened at the Queen Elizabeth.
Well, I'm questioning whether it happened at the Queen Elizabeth.
I think a number of the participants in the room have directed questions which really focus on whether you as chief executive had enough effective oversight of this major once-in-a-lifetime project that was taking place to build what was probably the biggest hospital in Europe as a building project at the time?
It was a campus, not a hospital building. Well, some of the marketing my PR people use was campus, because you had to add in the 800 beds that were already on the site, to which we added another 1,400.
Yeah. Well, do you accept that you showed a lack of effective oversight on this project with the contract?
No, I don't accept that. That's other people will form their own views, but I don't accept that. No.
Well, I think this might be an appropriate point, if I may, to take the short pause that we usually do at this stage, given the hour, so that I can see what the position is.
Mr. Calderwood, Mr. Connell would wish to canvass with the legal representatives in the room whether there are any more questions. So can I invite you to retire to the witness room, and this should maybe take 10 minutes.
Thank you.
Please stand. Please stand.
Some questions, I gather.
Yes, Lord.
I understand some further questions, Mr. Calderwood. No, Mr. Calderwood.
Thank you, Lord. I'm afraid some of these range from the narrow to the very broad. I'll just try and put them to you as concisely as I can. First one is perhaps my fault. When I was planning to go through your witness statement with you, I had originally intended to ask you this and avoided it due to a lack of time, but I've been asked to go back to it. In paragraph 449 of your witness statement, which is on page 125, you've referred to the fact that your successor, Jane Grant, had made a statement that she'd inherited a difficult set of circumstances, and you didn't think you knew what she meant by that. Well, first question, did she come and ask you about it?
You know, I mean, I should clarify that in relation to 449, the question I was asked was, Jane Grant made a public statement.
Yeah.
What is your comment? No, Jane and I haven't spoken out with meeting at two funerals of former colleagues since I retired.
And in responding to that, in the witness statement, you identified two issues that occurred to you. One was the 4B issue that we've already discussed, and I won't go back to that.
Yeah.
And the other one was what one might describe as a general financial challenge for the board. And I don't think, unless you particularly want to go there, I'll get you to read through that. And so overall, are you content with that?
Correct.
Thank you. At one point in your witness statement, I'm afraid I haven't had time to find it, you described the Schiehallion unit as an entirely different debate. Do you remember saying that? And if so, what did you mean by that?
Well, yeah, I remember saying it, and it was an answer to a question about the subsequent issues of the board taking the decision to do a major refurbishment of the area, and I'm saying that clearly in the media, what has come out since my retirement was that there were issues apparently with regard to the suitability of the unit. That resulted in the board deciding to spend, I think, according to the media, something between £6 and £9 million in doing additional works.
You may simply say you didn't do this, but I've been asked to put to you this, that when you had this new hospital project coming on stream, how did you seek assurance that the hospital environment, ventilation, water, et cetera, was safe for patients?
I personally, as I've explained, didn't do anything in the sense of the brief that the team were given in 2009 and subsequently developed through 2010 was to create, the best clinical facilities that would then be available in Scotland, and to provide these services, the infrastructure that would provide the best clinical environment for both the patients and the clinical teams.
At the time you were chief executive, can you tell me whether the board recognised patient safety was dependent on good governance?
Well, patient safety was a significant feature of the board's oversight, and good governance was considered to be part of the overall organisation of the board, not unique to patient safety.
one of the comments that's been fed back to me is that in a number of instances of issues that we've discussed over the past 2 days, you said, "Oh, I didn't know about that. No one raised this with me." Does that say anything to you about what the culture was at the time in the management of that hospital, that things didn't appear to percolate up to you?
I've clearly failed over the last 2 days to try and explain the breadth and width of the role of the organisational chief executive. I mean, to say that I would be aware of and be involved in and be consulted on everything before people did it would be an unworkable organisation. It would be like asking the chief constable of Police Scotland, did they know what was happening in the canteen at the Govan police station? The organisation can't work, at the scale of the organisation can't work like that. And I personally was charged by the board to take forward an annual work plan that was set out by the board, and the hospital, the procurement, construction and commissioning was one element of in most years, a 25-point performance plan for the chief executive. So I believed that the systems that we put in place were correct, they were properly resourced, and that the people were, in my opinion at the time, competent to take the project forward.
Can I ask you this, with the benefit of hindsight? What do you think went wrong on this project, and why did it go wrong?
I cannot honestly answer that question, because quite clearly issues are appearing, and now 10 years on, for which I don't have access to what is fact and what is speculation. So I believe it would be wrong of me to try and distill my thoughts into a statement.
Can I just ask you a much smaller question, which I've been asked to put? Craig Williams, that's a name familiar to you, I take it, from your time
yes.
there.
Mm-hmm.
Can you remember what his role was, as you recall it, in relation to the procurement and subsequent issues in the hospital?
My recollection of Dr. Williams was that I don't think he was involved in the project through the procurement and appointment of a multiplexer. I think at that time, from memory, he was consultant microbiologist, infection control doctor at York Hill. My understanding was that subsequently, in his role as the lead infection control doctor for Greater Glasgow and Clyde Health Board, he inputted into the latter stages of the project in, I believe, around about 2014 onwards. And obviously, as lead infection control doctor, he was working with Dr. Armstrong in relation to addressing the issues that were being brought up by the then appointed infection control team at the Queen Elizabeth.
Yeah, I think I just have two questions left. One of them does engage a question that you've already touched upon, so apologies if I need to go back to it. You explained that you had a work project which covered lots of things. I think the point's being suggested that the production of a hospital of this scale and this importance to the board was at least a very significant part of what the board had to do in those years in question. And would effective leadership therefore not mean that critical issues did require your personal attention and sign-off?
No, well, that didn't happen in that extent. The chief operating officer who had significant responsibilities, took the lead on the clinical issues concerning the Queen Elizabeth campus development. My role was to do with the strategy and the finance and the issues emerging external to the organisation in relation to the Queen Elizabeth.
The final question is this. I think you told us that a minute or two ago that you thought you had the correct systems in place, and as far as you understood, the correct people in place to deliver this project. Now, given what we now know about this project, does that mean there's nothing that you feel you need to take this opportunity to apologise for?
Well, given, with all due respect, I don't know what you know with regard to your statement about what we now know, because I don't know what is now known.
Well, let me go back to that then. We know that, we've heard that there were enormous problems on handover with the estates team not having time to do their work. We know water systems weren't maintained in the way they should have been. We know that there were problems with 4B, which led to the drastic result of patients moving over and then moving away again. We know that there were issues with 2A, which, albeit slightly after your time, led to that ward having to be decanted and ultimately redone. And we know, I think, and you probably know as well, that broadly speaking, the board's position is that they did not get the hospital they had hoped to get. Now, you were in place as chief executive from a date prior to contract signature to a date after handover.
Yeah.
And I'm just giving you this opportunity to consider whether, in light of your evidence to date, there's anything you feel you need to apologise for.
Well, clearly, on behalf, had I been still chief executive, I would be apologising. Should any of the actions that we took or any of the decisions that were taken gave rise to suboptimal outcomes for patients, that is devastating for me to hear or to acknowledge. But I would reiterate that when operational issues became apparent to me and or were reported to me, my statement sets out fully, and over the last 2 days we've discussed quite fully, we immediately took action to identify the problem and to create a remedy. Now, you use the word drastically transferring a patient population back. I regard that as a required outcome because of a perceived risk. We sought to remove that element of risk. That was exactly the same situation we saw it when we prudently suspended the paediatric hemato-oncology bone marrow transplant service. So at no time during my period did we not act on patient safety issues by seeking to either remove the patients from the risk or remove the risk from the environment that the patients were in. And I think that's demonstrated by my actions. My disappointment that certain of the systems appear to have failed, and that at the time, within project management arrangements in the NHS in Scotland, there was no fail-safe mechanism to catch them. I'm bitterly disappointed with that. I could go on to say that I'll therefore be bitterly disappointed on some of the people I appointed and bitterly disappointed in some of the external consultants that we employed to help us. But that's a personal view of someone long retired.
I have nothing further to ask, Lord.
Mr. Calderwood, that brings your evidence to an end and you're free to go. But before you go, can I thank you for your attendance today and yesterday and for the preparation that went into that evidence in responding to our questions for the preparation of the statement. But you're now free to go.
Thank you very much.
Now, my understanding is perhaps Mr. McIntosh will take the next witness.
He will
who
indeed,
is-
Lord.
Who is Ms. McQueen.
That's correct.
Well, we will see each other tomorrow, being well, and if I can wish you a good afternoon.
I stand.